Most chronic diseases do not resolve spontaneously and are generally not cured completely. Some can be immediately life-threatening, such as a heart attack or a stroke. Others can persist over time and can be intensive in terms of their management, for example, diabetes. Most chronic diseases persist in an individual through life, but are not always the cause of death. For example, arthritis is one of these. While some chronic diseases such as diabetes and arthritis have been known for centuries, infectious diseases dominated the health scene until the 19th century. For various reasons, including the fact that more people are living to an older age and improvements in the treatment and management, chronic diseases have increased in prevalence over the past. So my first chronic condition I'm going to be looking at will be asthma. So asthma is a funny one, as a lot of patients will suffer from an actual exercise-induced asthma, although there have been numerous studies completed showing how an increase in cardiovascular fitness can actually directly benefit the severity of your asthma. So there is evidence that the overall prevalence of asthma is increasing in the general population. Asthma is the leading cause of chronic illness and the most common chronic respiratory disorder in children. Asthma prevalence, severity and hospitalisation have increased over the last 4 decades, although there seems to have been a slight plateau in the asthma incidence in recent years. The prevalence still remains very high and true causes of the epidemic remain an enigma. The increase has affected many different populations, but the increase has disproportionately affected African Americans and Latinos living in poverty in the United States. By contrast, rural areas that have maintained a traditional lifestyle remain unaffected. Good examples have been studied in Africa, Australia and Papua New Guinea, and many explanations for the increase have been postulated, but none of them are sufficient to explain the scale or consistency of the change. Indeed, it is becoming increasingly evident that the cause of the changes in asthma must be multifactorial, including contributions from allergen exposure, hygiene and lifestyle. If we assume that the real increase in asthma has occurred between 1960 and 2000, what are the lifestyle changes that match this increase? The obvious candidates are diet and physical activity. Obesity, however, is a product of these changes that is easiest to measure. Obviously, these three are strongly interrelated, but they are good arguments for a primary role of either obesity itself, changes in diet, or decreased physical activity in the increase in asthma. Both the ACSM and the ATS both recommend exercise as a means of treatment for asthma. They conclude that there is no consensus on the optimal intensity of exercise, but recommend exercising at 50% of peak oxygen uptake, or at limits as tolerated by symptoms. Optimal duration of exercise is 20 to 30 minutes of continuous activity, although they admit this will be unrealistic for some patients at the beginning, but subjects with severe asthma, refractory or typical EIB prophylaxis might require optimal air conditions, for example heated humidified air, in order for them to exercise safely. The ACSM guidelines endorse exercise prescription for asthmatic subjects, but they mention that the majority of published data relate to chronic obstructive pulmonary disease. Treatment for asthma always seems to go towards the medical side of things, but the data has indicated that exercise actually increases in Treg cell function may play a role in the attenuation of airway inflammation or decreasing the inflammation in the airways. So these results indicate that moderate intensity aerobic exercise training may alter Treg cell function within the asthmatic airway. These reviews and recent controlled trials emphasise that although many of the studies of exercise conditioning in asthmatic patients involve different methods and outcome measures, the overwhelming majority of studies demonstrated the capacity for asthmatic subjects to exercise safely and significantly improve their cardiovascular fitness and also their quality of life. Obesity has also been linked with asthma. It has been associated with a reduction in deep breathing, contributing to airway narrowing through smooth muscle latching, decreased forced expiratory flow at 25 to 75% of forced vital capacity, reflux-induced bronchoconstriction, shortness of breath, increased wheezing, and increased release of inflammatory mediators. So another study evaluated the relationship between BMI and asthma among rural and urban children in Kenya and the United States, and they found that the urban American children had significantly higher BMIs and increased their prevalence of asthma. They also found that despite having larger lung volumes and being taller and heavier than the African children, the children in Atlanta had an FEV as a percentage of predicted value that was significantly lower. One randomized controlled trial demonstrated improved lung function in asthmatic subjects with dietary weight loss, and although there is an abundance of literature demonstrating the association of asthma and obesity, there is only one study that has established that obesity precedes asthma independent of activity level. Could it be that increased sedentary lifestyle has more influence on asthma prevalence than the severity of obesity and diet? Certainly, the association between obesity and asthma is not comparable with the association between obesity and diseases, such as type 2 diabetes. It is our view that there is a more logical case related to changes in physical activity and also a more convincing explanation for the effects of exercise on asthma than the effect of obesity on increased asthma. Six out of 10 randomized studies found significantly greater weight loss in exercise alone versus no treatment controls. The magnitude of the effect averaged 1 to 2 kilos. Only 2 to 13 studies found significant differences in initial weight loss for diet plus exercise versus diet only, although almost all studies pointed in this direction. 6 studies were identified with maintenance periods of at least 1 year. In 2 of the 6, there were significant long-term differences favouring diet plus exercise. But in every study considered, the direction of the difference favoured diet plus exercise. Other strong evidence showing benefits of exercise for long-term weight loss comes from correlation analysis, which consistently find that those individuals who report the greatest exercise have the best maintenance of weight loss. Although there is evidence that 30 minutes of moderate intensity physical activity may improve health outcomes, the amount of physical activity that may be necessary to control body weight may be 30 minutes every day. There is a growing body of scientific literature suggesting that at least 60 minutes of moderate intensity physical activity may be necessary to maximise weight loss and prevent significant weight regain. Moreover, adequate levels of physical activity appear to be important for the prevention of weight gain and the development of obesity. Physical activity also appears to have an independent effect on health-related outcomes when compared with body weight, suggesting that adequate levels of activity may counteract the negative influence of body weight on health outcomes. Thus, it is important to target intervention strategies to facilitate the adoption and maintenance of an adequate amount of physical activity in order to control your body weight. Other than diet and medication, exercise is considered one of the 3 cornerstones of good diabetes treatment. Nevertheless, current clinical guidelines on type 2 diabetes provide no detailed information on the modalities of effect exercise intervention in the treatment of type 2 diabetes. Based on a review of current available literature, exercise modalities are being identified to maximize the benefits of exercise intervention in the treatment of different type 2 diabetes subpopulations. Both endurance and resistance types of exercise have equal therapeutic strength to improve metabolic control in patients with type 2 diabetes. When applying endurance type exercise, energy expenditure should be equivalent to 1.7 to 2.1 on about 3 but preferably 5 days a week. In sarcopenic or severely deconditioned patients with type 2 diabetes, focus should lie on the implementation of resistance type exercises to reverse the decline in skeletal muscle mass and strength. Before choosing the most appropriate exercise modalities, the patient's disease stage should be well characterized, and an ECG stress test should be considered. Based on baseline aerobic fitness, level of comorbidities, body composition, and muscle strength, patients should be provided with an individually tailored exercise intervention program in order to optimize the therapeutic value. A multidisciplinary individualized approach and continued exercise training under personal supervision is essential to enhance compliance and allow long-term health benefits of an exercise intervention program. During my study of this assignment, I found that there have been thousands and thousands of articles, proving the benefit of exercise in these chronic conditions and how they can help over medications. It's just unfortunate that, these medication businesses are a business and that exercise always gets pushed on the back burner. But there definitely appears to be a linear relation between physical activity and health status, such that a further increase in physical activity and fitness will lead to additional improvements in health status. Perhaps the most significant change impacting healthcare in the 21st century is the growth of the median age of the population. A decline in fertility and 20-year increase in the average lifespan during the second half of the 20th century have resulted in significant changes, not just in the American population but also in the world. Improvements in life expectancy have produced consequences. The growing number of adults aged 65 years or older places large demands on the public health system and also on medical and social services. Chronic diseases that commonly affect older adults contribute to disability. They also help diminish quality of life and increase in the cost of basic health care and long-term care. The US Centre for Disease Control and Prevention has emphasised the importance of addressing the growing burden of disability and chronic illness, especially as it pertains to the cost of healthcare. Although many of the recent advancements in medical care derive from merging advanced technology with scientific methods, perhaps the most universal and effective treatment for chronic illness and disability in late life is physical exercise. Reductions in physical activity are associated with significant impairments and limitations in function, augmenting disablement and chronic illness. Exercise can reduce morbidity, reverse psychological impairments, ameliorate function loss, and are important means of both preventing and treating chronic disease. Exercise therapy is a fundamental aspect of rehabilitation, providing rehabilitation professionals with the opportunity to play an important role in meeting these public health challenges. So all of these articles, obviously, if patients are exercising, like exercise is free, or it can be free and not putting a burden on these public healthcare systems. So all these articles just proving the benefits of exercise on these chronic conditions. Maybe if that was recommended first, there wouldn't be such a burden on the healthcare systems these days. But I hope you've enjoyed my presentation and thank you for listening.